I want to start today by telling you all you're going to get are my views. Literally, this is the view outside my office where I've practiced for 19 of the last 29 years. But also, I'm not going to be giving you a lot of science and a lot of graphs and a level 2, kind of level 3 studies, academic approach. What I really want to do today is give you, I want you to walk away with an impression of what these patients look like, how to recognize traumatic brain injury, and then what are some of the options for treatment. Again, recognition. So you already know the mechanism of injury. It's a mechanically induced physiological disruption of brain function leading to either temporary or permanent neurologic deficits. It's some degree of focal injury superimposed on some degree of diffuse injury. It's that diffuse injury, that microscopic diffuse axonal injury, that is the hallmark of traumatic brain injury that makes it different from other injuries. And the focal injuries include the type of things Dr. Nanny just talked about, the interparenchymal contusion, subdurals, etc. There are certain areas of the brain that are more vulnerable to these injuries. The frontal lobes, the medial temporal lobes, and the limbic system, hence why we see a kind of stereotypical pattern of cognitive disruption and emotional dysregulation. I want to spend a few minutes on this scale. You've all seen this. This is how we determine the severity of TBI. And this is a simplified version of it. It gets a little more complicated, but it's important to know that the definition of mild, moderate, or severe is defined within the first 24, 48 hours of an injury. And the way it came about was they developed the Glasgow Coma scale really to communicate from the personnel at the scene to the personnel in the emergency room to give them an idea about what was going to approach their emergency room. And the only thing that really has ever borne out of any value to this is one, anybody with a Glasgow Coma score less than 8 had a very high probability of needing a neurosurgeon and had about a 40 to 50% mortality incidence. Anything less than 13 had about a 25 to 30% mortality incidence. And I think those statistics might be changing, so Dr. Nanny might argue with me about that. But what a mild brain injury is, it's really somebody who either had no loss of consciousness or a very brief loss of consciousness, very brief post-traumatic amnesia, high or normal Glasgow Coma scale. And what's important is imaging. Imaging is typically negative. Head CTs in the emergency room are typically negative. Very low probability of ever finding anything as long as you have this criteria and a patient who looks pretty normal, non-focal exam. And to answer your question about the CT scan, when to get a CT scan, the real question should be who can you avoid getting a CT scan in? Because I think there's an overwhelming concept that we're getting probably too many studies on these patients, especially CTs, which have a high radiation probability. The only other thing that panned out with this is for any patient with a post-traumatic amnesia greater than 14 days, there's a less than 20% likelihood that they'll ever go back to school or work at the same capacity they ever had. Other than that, there's about 30 years of enormous amounts of studies trying to figure out what permutation of these criteria and this information can lead to predictions in the acute phase, and basically none of them have panned out. And the bottom line is a mild injury can have a mild or a severe outcome, and a severe injury can have a mild or a severe outcome. So looking at outcomes is not at all related to this TBI severity. I've had patients in coma for 2 weeks who wake up and 2 weeks later go back to work. I've had patients in minor fender benders in parking lots who are disabled and never go back to work. So the outcomes are very challenging to predict. So mild is a term that we use synonymously with concussion. We use it synonymously with sports-related injuries. We typically reserve it for the more mild type impacts as well as the more mild type outcomes. And sometimes, in fact, again, a patient who meets the criteria for severe can also fall into this mild outcome scale. Other terms that have been used, we really, back in the 90s, we tried to get away from using closed head injury because that really just told you it wasn't a penetrating injury. A lot of people get that mixed up with whether or not you had surgery. It's not. It's just typical head trauma, but we really don't recommend using that anymore. Minor brain injury is a term that's out of date. And we have lots of colloquialisms in this country about things like got your bell rung and other things that really refer to this mild brain injury. The epidemiology of brain injury is confusing. The incidence is anywhere between 1.5 and I've heard as much as 4 million. Dr. Nanny said 1.7 million. And the reason it's so non-defined, why we can't hone in on a better number, is because roughly about 80 to 85% of them are mild. And about 40 to 50% of people with mild injury never actually seek medical attention, and so they're not counted on that scale. About 10 to 15% are moderate to severe, and less than 5% are severe, the type of patients that Dr. Nanny was talking about. So what I'm going to talk to you about today is predominantly mild brain injury, because it's the overwhelming number of what you'll see, and it's the overwhelming number of what's out there. Mild brain injury is still a very controversial diagnosis because we still haven't agreed upon a gold standard on how to make that diagnosis. As I said, imaging studies are typically negative, the standard imaging studies we do now, and there's no gold standard type of diagnostic tool. Some people argue that Neuropsych Testing is that gold standard tool. I disagree. I go with the American College of Rehabilitation Medicine, which says the best way to diagnose this is a clinician who is not only experienced in diagnosing, but also treating this population. And the reason for that is because there's some common features which we can recognize to help define it. And similarly, if it doesn't fit in the box, there are some features that help me recognize what other kind of complications there might be or other diagnostic evidence there might be. So you've all seen these lists. These are all the potential complications of mild brain injury, and you can sort of lump them into physical, cognitive, emotional, and I also like to focus on sleep. But rather than looking at lists, I'd like you to look at it like a more complex negative feedback loop system where, for example, you have somebody with a concussion who has bad post-traumatic headaches. As a result of that, they're not going to be able to think and work very well. As a result of that, they're going to be bummed and frustrated over their inability to work, then they're not going to be able to sleep, and then headache's going to get worse, et cetera, et cetera. And it begins to be a vicious cycle. Similarly, you can turn that into a positive feedback loop system by tapping into any one of these areas and attempting to make change, and you'll positively impact the outcome. So what does an acute concussed patient look like? Basically, the best way to think about it is brain inflammation. And what these folks look like is, if you want to use an analogy, it's the worst hangover you've ever had. Or for people with migraines, it's a really severe migraine. But unlike those, it doesn't go away necessarily in a couple days. And these folks, they're sleepy, they have severe headache, they're irritable, hyper-emotional, light sensitive, noise sensitive. And what our current state of treatment is to, once they're cleared from the ER or the primary care's office, they're sent home to rest. They're told to lower their physical and cognitive stimulation. And we should add a few things on that. We should be telling them not to drive, not to use alcohol. We can provide them some information about work and school accommodations. But the bottom line is really to lower the stimulation, lower the stress on the brain. But the $64 million question is, how much rest and for how long? Well, about a decade ago, when sports-related concussions became the in diagnosis and everybody was developing these programs and clinics to treat it, it became very popular, and the pendulum swung to that side of saying rest. Rest is the magic cure. And over those period of time, studies have not panned out to show that rest is that important. And in fact, especially in the adolescent teenage population, the more you impose strict rest on them, secondary complications like depression and lowering their expectations of recovery start setting in. So the pendulum has come back, and I like that because it's come back to what I've always practiced, which is more of an as tolerated approach to these folks. So in other words, yes, strict brain rest for probably 2 or 3 days after the injury is probably valuable. Beyond that, if the patient can tolerate looking at their TV and looking at their computer and their phone, don't impose this strict restriction. I get patients who come in a month later and still haven't done any of this stuff because somebody told them not to. Trust me, if they're in a severe post-concussive state of affairs, they're not going to want to do those things. So they're going to do some self-imposing of restrictions. But if they can tolerate it, the goal is to start to return to normal activity as tolerated. So the prognosis, and when I talk about mild brain injury here, I'm talking about that get up and walk away from it kind of injury. Whether or not they lost consciousness, and you don't have to have a loss of consciousness to diagnose mild traumatic brain injury, and whether or not they went to the emergency room. So for that population, roughly speaking, about 50% recover in about 10 to 14 days. About 85% recover in about 3 months. The problem with that is about 15% don't recover in 3 months, and that's what we call the post-concussion syndrome. Back in the day, I've been around this a long time, we used to reserve that term for anybody who had symptoms persisting beyond 3 months. But again, as sports concussion popularity came on board, that distinction lost its importance. And in addition, when ICD-10 came along, it became necessary for us to get paid to start using more codes, and ICD-10 allows you to use post-concussion syndrome right away. So now the term is used, and including me, I've finally kind of caved into the pressure of starting to use the term right away. I get referred patients out of the ER with the term post-concussion syndrome 3 or 4 days post-injury now. So what does a patient with post-concussion syndrome look like? It's really best understood as an injury of energy. It's a condition of deficiency, and they have deficiencies in energy, in sleep, in attention, concentration, executive function skills. They have no reserve. They can't get to work. They're really struggling from an energetic standpoint. And a speech pathologist here in the Boulder area who back in the, she just retired about a decade ago, but back in the 80s, she was very astute and figured out this injury of energy analogy and made up this, what we call energy pie. And it's definitely used ubiquitously locally. I don't know if it's used nationally or not, but you've probably seen this before. So this concept is that this is how you allocate energy in a normal person before a brain injury. Every day you get up, you go to work or school, you get along with friends and family, you get some exercise, you try to stay healthy. But if any one of these domains took on greater energetic need, you would be able to tap into this big reserve. After an injury, however, those domains start taking on more energy needs. It takes longer, it's more effort, they fatigue quicker, and there's very little reserve now to tap into. Another analogy I like to use, if the patient used to be an 8th generation Intel Pentium processor installed in a lightweight Air notebook with all the bells and whistles, etc., all of a sudden now, this is what they're functioning like. They're slower, they can't do as much, as fast or for as long, and they can't have as many windows open at the same time. And I don't know if any of you are old enough to remember these computers, but they used to crash all the time. So when your energy runs out and you have no reserve to tap into, the brain basically crashes, and these patients talk about that kind of brain crash. I'm going to show you some anatomical correlates of this injury of energy. This is a brain Spect scan. This is a functional imaging scan looking at brain blood flow, which is equivalent to the need for oxygen, which is equivalent for the need for metabolism. On the left, you see a normal brain, and this is the scale, normal blood flow and decreased blood flow as you go down the scale. On the right, you see a brain with a traumatic brain injury, and there's a significant amount of hypoperfusion relative to normal, which equates to hypometabolism, which equates to an injury of energy. This is another important Spect scan. This is a sagittal view of an individual with a traumatic brain injury, and this is the way we use Spect scans to diagnose traumatic brain injury. This is a brain-injured brain at rest, eyes closed, just relaxing. This is their frontal lobe, and you see a certain amount of blood flow, of metabolism. Then when you give that same patient a cognitively demanding task, What you would expect and what you see in a normal person is if their frontal lobes go into high gear, into high demand, they're going to need more oxygen. They're going to need more metabolism to carry off that task, and their blood flow should go up. And what you see in traumatic brain injury is the opposite, or a paradoxical reaction, where their blood flow actually goes down. And that's what your patients will describe to you, that they can't think, they can't sustain cognitive effort for very long. This is a special technique, diffusion tensor imaging. It's a type of MRI where the computer teases out the difference between gray matter and white matter tracks, and then it superimposes these pretty rainbow colors on the white matter tracks. And then if you further take out the gray matter, what you're left with is this beautiful picture of the white matter tracks of the brain. On the left, you have a normal brain, and on the right, you have a brain with a traumatic brain injury, which you see a relative reduction in the amount of white matter tracks, blatant holes in the tracks. So what is neurotrauma rehab? Neurotrauma rehab is a holistic team approach to treating not only the diagnosis and its symptoms, but how those symptoms impact the patient, their family, their job, their setting in their communities, etc. It takes a team approach, including the patient at the top of the team, and hopefully you have a good team, and hopefully you have a team that's experienced in this diagnosis. The key aspects of that treatment are education, validation, and compensation. I'm a true believer that knowledge is power. The more these patients know what they're going through and why, and understand that analogy of the injury of energy, the more it makes sense to them, rather than just being told you have a concussion, go home and rest and wait it out. Validation is critical because they need to know, no, you're not going crazy, no, you don't have a new brain tumor, no, there's not a bleed that we missed, no, you don't have early Alzheimer's, and their family needs some similar validation like that. And then compensation. How do you now learn to live with the computer power of a 486 when you have the job and expectations of somebody with that fancier computer? So the real bottom line of treatment is energy management, getting them to know how to recognize their symptoms, how to take brain breaks, which recharge the battery, all sorts of job simplifications, as much as possible, taking all of the things off of their plate, demand-wise, energy demand-wise, simplifying their life, allowing recovery, and then going back as they can. So the team involves PTOT, speech, and counseling. You've seen these lists before. This is how we kind of divide and conquer. There's a lot of overlap between the various disciplines. And hopefully you have a group that communicates and works well together. Part of the clinical evaluation is what you would know, standard. Understanding the mechanism of injury, how much speed and gravity and kind of went into the injury, kind of helps you get a sense of the severity. What the medical history of the person is, what brain got injured, is as critical as the mechanism of the injury. Good review of systems, and then a clinical and physical examination, concussion specific. Make sure you don't ignore the differential diagnosis. If there's any other possibility that could be explaining what's going on with this patient, and then begin an initial management plan. As the doc on the team, this is what I like to focus on. First and foremost is education, and then sleep, sleep, sleep. In my practice, I think sleep is the most important drug I have ever given any patient. And the more you focus on that early on, most of the other stuff will tend to fall into place. And then I like to focus on the physical side. Pain. What can I do to start to address the pain to get that off of the complication list? And then I either go for the emotional or cognitive or both, depending on the priority that they present. Dysomnias after TBI are very common. First and foremost, they present with hypersomnia, meaning they sleep excessively the first couple days after the injury. And in fact, that is so important that if you don't see that they've been hypersomnolent, you might even want to think about other potential diagnoses. Pain or anxiety keeps you awake. Brain injury makes you sleep. And the hypersomnolence of brain injury always trumps the hyposleep, or the lack of sleep caused by anxiety or pain. Then it's almost like a flip gets switched, or is it a switch? Switch gets flipped, and then they developed insomnia. And it's either early or middle, meaning sleep initiation or sleep maintenance, or they wake up in the middle of the night in panic attacks, bad dreams, things like that. Make sure you take a good history. If you just ask them, are you sleeping? They'll say okay. But if you ask more in depth, you might find that their restorative sleep isn't as good as it should be. And that's critical because that's when the brain heals, is during restorative sleep. So a lot of times these folks just wake up as tired as they were when they went to bed. And that goes on day after day. There's often something called circadian shift disorder. And that's when they can't fall asleep at night and then they can't wake up in the morning. And that seems so simplistic. Well, just go to bed earlier. Like the rest of us, we adjust every 6 months to daylight savings time. But it's much more dense than that, much more difficult to overcome. And then at least consider the possibilities of sleep apnea and restless leg syndrome, which can either be a pre-existing condition, a condition that was exacerbated by the head injury, or actually caused by the brain injury. So sleep treatment is pretty much your standard run-of-the-mill sleep treatment. A lot of education on sleep hygiene education, things like not using blue screens, no alcohol, no caffeine, for people who exercise and impede sleep. All those kind of strategies are helpful. Make sure you treat the underlying disorder. If anxiety is what's keeping them up, address the anxiety, pain, etc. You can certainly intervene with medications, and I like to early. There's a lot of over-the-counter, that's supposed to say OCT, over-the-counter, OTC rather, over-the-counter medications. Be careful with those. A lot of folks will be using those, and you can develop tolerance to those pretty quick. CBDs, don't be afraid to ask patients or don't be afraid to guide them to them. They're very effective in this population because they're very good for sleep and anxiety, the main issues that we're concerned with. And then beyond that, I delve into prescription medications. Some non-medicinal options are alpha stim units, which is a little device out of Canada. You put the electrodes on your earlobes and you wear a little iPod-sized device, which is kind of like non-medicinal Valium. It's very effective for pain and anxiety. Unfortunately, it's not covered. And then biofeedback, and there's lots of different techniques for that. The physical side of rehabilitation, what we do, is pretty standard, what you know physical therapists do. The only addition to what's standard is a little bit more emphasis on the visual vestibular issues, and also post-traumatic headache. The headaches are extremely common. In mild traumatic brain injury, about 90% of patients show up with some degree of headache early on. And that is what's important about that is in severe traumatic brain injury, it's the opposite. It's almost less than 10% that have severe headache, which really doesn't make sense, but really emphasizes the fact that these are different animals. Mild brain injury and severe injury are not the same. These headaches are harder to treat than non-traumatic brain injury headaches, and also the severity of the headache on presentation is one of the few symptoms that is a sign of a negative prognosis for that patient in terms of the recovery. And as you might expect, it's kind of obvious, the longer the headache hangs around, the less likely it is to go away. These headaches are usually a mixed bag. There's some degree of muscle tension headache, stress headache, cervicogenic headache, myofascial, facetogenic, but there's always a component of migraine in there and can be treated like migraine. And especially as the headaches start to let up, the migraine component of it becomes more intermittent, and the musculoskeletal component is the underlying more constant headache, and you can start treating those migraines on a more intermittent with migraine abortive type medications. Always think of analgesic rebound. It's not uncommon for these folks to come in weeks and months later, take an Advil or Tylenol or Excedrin, one of the worst, on a round-the-clock basis. So you have to help wean them off the analgesic before you can rule out the possibility that it's an analgesic rebound. The treatment of these headaches are pretty run-of-the-mill headache treatment plans, PT, acupuncture, IMS or dry needling, Botox, and again CBD can be very effective for this population. The visual vestibular complaints are also present in about 90% of patients, and this became more obvious when the sports-related concussions became popular, and I think it is more common in that population. But what I want to focus on is, first of all, these symptoms are often short-lived, recover spontaneously, and the treatment is very challenging, very unpleasant. These treatments exacerbate headache, dizziness, nausea, fatigue, and those are the symptoms we're trying to treat. So timing of this kind of therapy is critical. You don't want to do it too soon. You want to let them get a little grounded before you do that. The key about vision issues, post-traumatic vision syndrome, it doesn't involve the health of the eyeball, so ophthalmologists aren't typically involved or interested. It doesn't involve the strength of prescription glasses they need, so normal optometrists are not typically involved or interested. What it involves is how the eyes work as a team to send information to the brain. And what is typically impaired is the eye tracking ability. So their ability to do horizontal and vertical tracking, their convergence down and in to read, their divergence, and also accommodation going from near to far quickly and smoothly. And what happens if there's an asymmetry from one eye to the other, or both eyes are slow and impaired, the information doesn't come in as smoothly, and that discombobulates the brain. And then, as you well know, the visual vestibular systems are intimately tied together. So when one is off, the other is typically off. And the vestibular, the pure vestibular stuff is more the dizziness and gaze fixation and the ability to coordinate and be smooth in your environment. I like to think of the dizziness as three possibilities. Vertigo, which is the room spinning, which can be positional or not, and that's easily treated with physical therapy. Disequilibrium, which is the more common of them, and that's the patient will describe. They don't feel firmly planted on the ground. It feels like their world is moving, and that's very disconcerting for the patients. And then the final one is lightheadedness, which you've all had that where you get up too fast from a head down position and get a bit of a head rush. Well, they get that frequently with a lot of different positional changes. It's more severe and it lasts longer. All of those things can be addressed by the vestibular therapy. But again, timing is critical. Cognitive therapy is the thing that speech-language pathologists do, and they address the higher level cognitive issues that these people are dealing with. And again, it's mostly fatigue. I like to divide cognitive therapy into two types, what I call the functional-based therapy and then the process-specific therapy, or the cognitive retraining. The functional-based therapy is where the therapist helps further along that education, get the patient to understand this, particularly in the context of this being an injury of energy, providing energy management strategies, and also doing some case management. They're the ones who typically start talking to school and work and planning for the necessary accommodations as the patient recovers. Once those goals are met, the therapist can switch to more assessments and then looking at the strengths and weaknesses of the patient. A simple example of that is they might test and find that an individual has better visual learning and memory than auditory learning and memory. And so they will gear their therapies to help develop strategies to rely on their strengths, the visual learning, and to strengthen at the same time their weaknesses, the auditory learning. And then the final kind of therapy is what are called neuromodulation therapies, and include biofeedback, neurofeedback, EEG, and those have been shown to help with fatigue, attention, and anxiety. I want to spend a second on neurofatigue. Neurofatigue is really the overwhelming complaint these people focus on. They don't come in and say, I have neurofatigue. They come in and say, I'm tired, my memory's shot, I can't think, I can't sustain any cognitive activity, I can't do my work, I'm making lots of mistakes. And I want to make a distinction between what is cognition and what is conation. Cognition is the mental process of acquiring knowledge and understanding through thought, experience, and the senses, and it involves the use of memory, attention, and executive function skills, frontal lobes. Conation, on the other hand, is the battery power necessary to power up and then sustain that cognitive activity over an appreciable period of time for that patient to be productive. So in other words, they can go into work and they can sit down in front of the computer or whatever they do for 20 minutes or 2 hours, and then boom, they hit a wall and literally cannot go on further. And again, they don't have that reserve to tap into. It's easier when they have clear-cut deficits of cognition, and that shows up on cognitive testing or neuropsych testing, but those patients could still be struggling, and it's because it's the deficit in conation that's preventing them from getting back to whatever their normalcy was work-wise. The final modality of therapy is the mental health work, and the psychological and emotional side of the presentation of these patients is wide-ranged, but it's typically some degree of mood lability, depression, irritability, frequent crying, and the therapies are really what you're used to, standard therapy for mood disorders, with the exception of the increase in anxiety and work for trauma therapy. So the treatment focuses again on sleep. If it hasn't already occurred, hopefully the mental health provider is providing them additional education on sleep hygiene and other good strategies, relaxation, breathing strategies, etc. A lot of supportive counseling. You know, these people need support to adjust to the changes that have gone on in their life. They're often unable to go back to work, have financial stresses, marital stresses, etc. Trauma counseling is a big component of what we do because so many of these injuries have a trauma background, and patients who have a trauma background are more vulnerable to these complications. My favorite is EMDR, eye movement desensitization and reprocessing. You can forget I ever said that. Everybody calls it EMDR. The other one that's very famous locally here is somatic experience. But it's the key is to finding a good therapist who can provide for that additional component of therapy, which is so important. And last but not least is medication. If I had about 90 minutes, I would go on a tangent now and talk about post-traumatic stress disorder because it is such a critical comorbidity of this patient population. But I don't, so I'm not going to. I'm going to suffice it to leave it with this slide, but at least give it a consideration. The one point I do want to make, though, is I avoid the term or the letter D and call it post-traumatic stress reaction because these patients don't necessarily meet like the DSM-5 criteria for PTSD, but that criteria is ridiculous. And so we all recognize it, we diagnose it, we treat it, but we call it whatever we want, PTSD or PTSR. Anyway, the goal of therapies in post-concussion syndrome in summary is to educate, validate, compensate, begin to provide accommodations for the patient, and then start recognizing the individual symptoms that that patient has and address those individual symptoms as you would in any other condition. I'm going to talk briefly on neuropharmacology, some of the do's. Medications should never replace cognitive therapy or counseling. They're just to supplement them. Always focus first on sleep, because if you get them sleeping, sometimes the pain and depression goes away by themselves. Followed by focusing on the headache and other pain conditions, recognizing and treating PTSD, and then again, just identifying all the various specific symptoms in the physical, cognitive, and emotional realm and figuring out how you're going to address those in conjunction with the therapies. The medication don'ts. Make sure the patient is avoiding alcohol. Alcohol is a neurotoxin. You don't want them to be pouring alcohol or a neurotoxin while their brain is actively trying to heal. Avoid narcotics for all the same reasons that Vicki mentioned earlier in terms of, well, one, notoriously, they're ineffective for post-traumatic headache. Second is you have no idea if that headache's going to last 2 days, 2 weeks, 2 months, or 2 years. And you're heading down a slippery slope if you choose to continue to provide narcotics beyond the first week or so. Obviously, that's complicated by associated injuries, fractures, and stuff like that, but for brain injury, that's an important point. The other point is avoid neuroleptics and benzodiazepines. They're both dirty drugs, particularly benzodiazepines are dirty drugs, but more importantly, they're both contraindicated in what the brain needs to do to recover. Particularly benzodiazepines are the opposite of what the brain needs to recover. So avoid them. The issues of medication and traumatic brain injury, there's not one single drug in this country that's FDA approved to treat traumatic brain injury. So we borrow, as we do in many other diagnoses, we borrow from other diagnoses that do have a medication that's FDA approved. And so again, if you focus on the individual symptoms that the patient is struggling with, you can treat those symptoms. I'm just going to talk about two meds. Psychostimulants, because they're used a lot, they're used early, and they're used very effectively. They're good because they're what I call on-off meds. The patient does not have to take them every day, but they're a very effective tool to use when they're struggling with neural fatigue. They're easy to monitor. They're easy to monitor the side effects. They're pretty well tolerated if you control the doses. There is a black box in the PDR for seizures, and I want to identify that is not true. That was years ago put in there, and once you have a black box, you can never get rid of it. And psychostimulants are the most frequently studied medication in pediatrics, and there is no evidence that they cause seizures or even lower seizure thresholds. And in fact, there was a study or two that showed that they might raise seizure thresholds. So that's an important point. What there is a lot of studies that show all of the symptoms that are improved with stimulants. That's probably a bit of an overstatement. There's two things I like about psychostimulants, and it's the same symptoms that are the two most common side effects, and that's insomnia and headache. If used correctly and dosed correctly, you can address both of those complaints, both acutely and chronically. And also there is evidence that if used correctly, it can help bring the frontal lobes back online quicker. In other words, we've taken a population of patients who were 2 years post-injury and started them on psychostimulants, and using TOVA testing, a neuropsych battery, a specific sub-battery, and followed them over time and showed that they could come off the psychostimulants and their TOVA tests would normalize. So we do know that it can help, actually more than a Band-Aid effect, it can help promote recovery. There are some limitations to the use of psychostimulants. They are controlled 2 substances, so you can't prescribe more than 1 month at a time. There is an abuse potential and a diversion potential. They're the most abused drug on college campuses. Well, probably next to pot and alcohol, and then there's a risk for tolerance development, but that actually is not true for the attention component. It is true for the euphoria, weight loss, and things like that, but it is not true for the attention benefit component of stimulants. And then there's a lot of stigma around psychostimulants, so a lot of patients aren't necessarily interested in doing that. Eventually, they may acquiesce. The second medication I want to talk about are the Alzheimer's medications, the acetylcholinesterase inhibitors, or what I call procholinergics. About a decade ago, it came out very popular that this would be a good medication to use in this patient population, and the studies really haven't been very impressive. And in fact, there's starting to be some studies on Alzheimer's that show that they may actually worsen symptoms. Go figure. Anyway, from my standpoint, the benefits really are very modest, and the side effects are really significant, mostly GI. And most patients fall off of studies on these meds because of the GI intolerance. They're also very costly. There's also some thought that there is a neuroprotective component to these medications. Namenda was the one most identified for that potential, and particularly for things like if you have a patient who's had a lot of concussions and they're worried about chronic traumatic encephalopathy, the problem with that is they would need to stay on that medication indefinitely, and I know very few patients who are willing to do that. So the clinical pearls for medications are consider your timing. First and foremost, allow spontaneous recovery to occur. See the patient early, give them a lot of support and education, but don't load them up on a bunch of medications. But when you do, go low, meaning use low doses, and go slow. Do one thing at a time, make one change at a time, etc. Know that this is the diagnosis you're treating, and then focus on the specific symptoms and treat those symptoms. Also know how many cooks are in the kitchen, because these patients see a lot of providers, and if a lot of different providers are prescribing medications and there's a lot of symptoms, there's a really high risk for polypharmacy in this group, and that really needs to be avoided. You got to know your drug-drug interactions, and there's a lot of thought out there that this kind of treatment should be limited to a single practitioner and an experienced practitioner. So let's say you've done a good job, you've created a team, you've given all the education and accommodations and et cetera, and everything's going well, but the symptoms persist. So I think when post-concussion syndrome lost its 3-month significance, along came persistent post-concussion syndrome. And I don't know when we use this now, but patients definitely more than 3 months and probably tending toward a year get this unfortunate added diagnosis. So who's at risk for persistent symptoms? The key to think about is not only the mechanism of injury, how much energy went into the brain, how much speed and gravity and angulation and all those factors that probably play into traumatic brain injury, but also who was the brain that got injured. Premorbid factors, including age, are significant. We used to say kids, oh, they do great, they heal from anything. No, evidence now shows that kids, actually, they have a more complete outcome, but it takes longer. Older folks, after 45, tend to not have as complete an outcome, and the older you get, the worse it is, as you might imagine. Women at all ages do poorly compared to men. Anybody with a prior concussion does poorly, and it's thought that over time it's going to take less and less of a ding to have more and more of an impact in terms of severity and duration. In addition, if anybody had any of those prior symptoms, if you look at the symptoms of concussion, if anyone had one of those common symptoms, whether that be headache, migraine, attention deficit disorder, learning disability, anxiety, depression, they are much more likely to have that symptom and lasting longer than other folks, comparatively speaking. Substance abuse and known psychosocial stressors both contribute to poor outcomes, and then genetics, probably in a way that we don't fully comprehend or can't test or treat at this point in time. For this group of patients, the goal of therapy somewhat shifts, because now you have to do more aggressive school and job accommodations. Their family medical leave acts have probably worn out by now. They may be transitioning from short-term to long-term disability. As a result, their therapies need to take on more emphasis. This is where I like to start considering neuropsych testing. I'm not a fan of doing neuropsych testing earlier than that, and really it's best for situations that require medical legal evidence as opposed to just clinical evidence of the diagnosis. This is where you might want to consider other specialty referrals if you haven't already done that, consider medications, and again, there's probably some likelihood that a lot of these patients by now are auto accident related, and there may be some medical legal issues coming up at about that point in time. So in summary, traumatic brain injury is an injury of energy. Treatment should focus on energy conservation techniques, teamwork, go low, go slow, both with treatment as well as medications. Timing is critical, and the goal is to be kind and gentle to that recovering brain, while that individual gradually brings back on all their energy demands, while they try to get back to normalcy in their life, however long that will take. Recovery is basically the restoration of their reserve. Another word I like to use is resiliency. When you know that patient can handle whatever physical, cognitive, or emotional stressor you throw at them, and they can handle it. In summary, the two long-lasting complications are decreased energy to manage the battery that is the computer for the brain, i.e. cognitive fatigue, and decreased capacity to handle stress. And recovery takes 3 things: time, time, time. Something that's already also come up today. And that time is unpredictable. For those of you who don't know me, I always slip in a picture of my kids. These are my adorable children. Now they're scruffy little old men, but this is what they long ago used to look like. I wanted to make a comment about helmets. Am I good on time? Does anyone? Time is out?
We're getting close, but helmets are important. So
Yes.
All right, helmets are important. The best prevention for traumatic brain injury, first and foremost, are parents. Second of all, adults who make wise decisions, like wearing helmets, using your seat belt, not texting and driving or driving under distraction in any way, and also looking both ways in pedestrian crosswalks in Boulder, which are some of the most dangerous places I know. Evidence is mounting and very impressive that helmets work, but the reality is they have more of an impact on the lower side of the scale, on less severe injuries, less impact injuries, and they begin to lose their significance for higher impact injuries. And that's because speed and gravity will always win out. These helmets are designed for speeds less than 15 miles an hour, and athletes, and particularly people in Boulder, tend to go faster, and so there is some limitations to the helmets, but overall they are helpful. Speed and gravity will always win out, but again, the vast majority of these patients recover. So don't stop skiing. I wanted to put this slide up because I've had so many cartoons, and I wanted to show that this is serious. This is something to be really considerate of what goes on in accidents. There is a special helmet. It's designed to absorb the forces in a head injury, and these are MIPS. They're readily available. They're a little more expensive. Would strongly recommend you replace all your helmets and get these, and also tell your patients about that. One way or the other, be smart and wear a helmet. I have one more tangent. Can I go on my last tangent?
Sure.
Unless people want questions. I'll be around for questions. So if I was to devise, or if we were to devise the perfect treatment for traumatic brain injury, it would involve two things. One is you would want that treatment to change the underlying pathophysiology of the condition. And second, you would want to minimize the duration of symptoms of that condition. And to understand the condition, the pathophysiology is inflammation. And hyperbaric oxygen therapy is the best treatment to treat inflammation. And what hyperbaric oxygen therapy is, it's breathing higher than atmospheric doses of oxygen under higher than atmospheric pressures. And as a result of that, what you get is about 15 times the normal amount of oxygen flowing around the body and available to every cell in the body. And what we know about high dose oxygen under pressure is it's a fabulous wound healer. It's a fabulous anti-inflammatory. It's an antibiotic. It promotes neuroplasticity, which is the brain's ability to heal itself, neovascularization, and the repair of soft tissues. This is a wound. It's an acute wound of the foot, pre and post injury. I honestly don't know, or pre and post hyperbaric rather, I honestly don't know how long and how many treatments that patient had. And you might look at that and say, well, that wound looks like it would have healed anyway, and it probably would have. Here's a wound that's not going to heal anyway. This is a diabetic foot ulcer, and this foot is quickly headed towards amputation until the hyperbaric oxygen therapy came along, and you see the tremendous effect of wound healing. And if it can work in wounds we can see, why wouldn't it work in wounds we can't see? Remember, mild traumatic brain injury doesn't even show up on CT or normal MRI imaging. And even in severe injuries. What these injuries are wounds in the brain. And hyperbaric oxygen therapy is safe. It's physician prescribed and supervised. It's non-invasive, non-painful, has minimal side effects, except for the fact that it's not insurance covered. It's time consuming, and it's not a cure, but it is a phenomenal supplement to the treatment as usual. And it works, and I know that because I'm going on several hundred patients over the past decade with really awesome outcomes, and I'd be glad to talk to any of you about those.